All right, my name is Tara Haelle, and I'd like to welcome you to today's webinar, Key Issues Before a Key CDC Meeting, Essential Vaccine Information for Reporters. I'm the Health Beat Leader on Infectious Disease for the Association of Healthcare Journalists, and AHCJ is excited to partner with the Expert Vaccine Analysis Team, a team of internationally recognized and trusted vaccine experts whose scientists and physicians have a long track record of leadership in vaccines, infectious disease, and public health. HCJ is the largest organization of health journalists in the US, and we've partnered with EVAT to provide journalists with an essential briefing on what issues are likely to be discussed at the CDC's upcoming advisory committee on immunization practices. This is the committee that determines CDC vaccination policy for the nation, and key issues will be discussed at the meeting on December 4th and 5th, Thursday and Friday of this week, including whether the hepatitis B vaccine will continue to be recommended at birth, and possibly whether a certain combination vaccine, such as the measles, mumps, rubella, varicella, chickenpox vaccine, will continue to be recommended. Joining us today, we have Paul Offit, an infectious disease attending physician and director of the Vaccine Education Center at Children's Hospital of Philadelphia. Jesse Goodman, a professor of medicine and infectious disease and attending physician at Georgetown University. And Michael Ninberg, former executive director of the Hepatitis Education Project and a patient advocate. We're going to start with Dr. Offit before going on to Mr. Ninberg and Dr. Goodman. Dr. Offit will begin with an overview of what to know about the hepatitis B birth dose. While the speakers are presenting, you're welcome to ask questions at any time by typing them into the Q&A space. That's where the question mark is at the bottom of the Zoom frame. So you don't put the comments you don't put them in the comment area. You put them in the Q&A space. And after each of our speakers have gone, I'll be fielding the questions to them. So we will go ahead and get started. Dr. Offit, take it away.
Thanks, Tara. So on Thursday, December the 4th, starting at 8 a.m., there was an entire day of discussion about hepatitis B vaccine with a vote at the end of the day, presumably about delaying the hepatitis B birth dose. So let's talk about why we have a hepatitis B birth dose and what the possible consequences of delaying it could be. So if a mother has hepatitis B infection and is screened in the first trimester as having hepatitis B infection, and then her child is born through a birth canal that contains blood and therefore contains hepatitis B virus, that child has about an 85% chance of developing hepatitis B. If you get infected with hepatitis B in your first year of life, you have roughly a 90% chance of going on to develop chronic disease, specifically cirrhosis, which is chronic liver disease, or liver cancer. If you're infected with hepatitis B in the first 5 years of life, you have a roughly 25% chance of going on to develop chronic infection, i.e. a cirrhosis or liver cancer. That number dramatically drops off as an adult to less than 5%, really, of going on. If you're infected as an adult, you have less than a 5% chance, really, of going on to develop these chronic diseases. So that's a very vulnerable period of time. And that's why we focus on it. So in 1981, we created the first hepatitis B vaccine. In 1982, that vaccine was recommended as a birth dose for every child whose mother was hepatitis B surface antigen positive in the first trimester. In 1988, that recommendation was extended to include high-risk groups, such as Southeast Asian immigrants and others, to get a birth where the child gets a birth dose of hepatitis B. By 1991, those two recommendations hadn't made a huge difference. They'd made a little difference, but not a huge difference. So in 1991, the recommendation was everybody at birth gets a hepatitis B vaccine. All newborns in the first 24 hours of life, or at least before they leave the hospital, gets a hepatitis B vaccine. And that has caused a dramatic decline in the incidence of the disease. So where were we in 1991? In 1991, there were roughly 30,000 children less than 10 years of age who got hepatitis B infection. Half of them got it from their mothers, passing through a birth canal that had hepatitis B virus in it, but the other half didn't. The other roughly 15,000 children less than 10 years of age who got hepatitis B didn't get it from their mothers. So there's 15,000 cases a year then in 1991. So where did they get it from? They didn't get it because from being sex workers. They didn't get it from being intravenous drug users. They got it from coming into relatively casual contact with one of the millions of people in this country who are chronically infected with the virus. Because if you are chronically infected, you have a fairly high viral load in your bloodstream. And so if you have even unseen amounts of blood on a washcloth or a towel or a nail clipper, you can inadvertently get that infected with that virus. And that's how they got it. That's how those other 15,000 people got it. So we virtually eliminated this disease in the less than 10 years old. So why give a hepatitis B birth dose? I think, first of all, there are several thousand new hepatitis B infections every year in this country. There are still many thousands of people who go on to develop chronic hepatitis B in this country every year. There's at least 2.4 million people who have chronic hepatitis B. So why give the birth dose? One is that not everyone is screened. There's about, as compared to most developed world countries where there's virtually 100% screening in the first trimester, in this country it's closer to 85%. So 15% of women aren't screened in the first trimester. Two, even if you are screened, there's about a 5% false negative rate for that screening test, which is to say you're falsely reassured that you don't have hepatitis B. Third is that you still can get a hepatitis B infection in your second or third trimester, for which you wouldn't know from just that first trimester screening. And the next is that you don't know who you're coming in contact with in those first few years of life that might have somebody who might have hepatitis B, chronic hepatitis B, and not know it, of whom there are millions of people. People are in the daycare center, or Uncle Bob, who comes over to visit the child and has contact with the child. So you don't know that. And given that it is a very vulnerable time, that you have a 90% chance of going on to develop chronic liver disease if you are infected in that first year or frankly first few years of life. That's why the birth dose. And so it does worry me that if we delay the birth dose, that's going to make it more difficult than for people to finish that series, because that's one thing that was found to be true. If you get the birth dose, you're much more likely to complete the series than if you don't get the birth dose. And there are also combination vaccines that contain hepatitis B in it that are given by different schedules, some at 2, 4, and 6 months of age, another at 0, 1, and 6 months of age. So it can be confusing. So I guess we'll see what happens. I will say clearly that I am worried. We don't have an ACIP anymore. We had an ACIP, but on June the 9th, Robert F. Kennedy Jr. fired 17 experts and replaced them with people who, like him, have an anti-vaccine, anti-science bias. So the decisions that are being made, I think, may not be made based on facts, because this is a safe vaccine. It's equally safe if it's given at 0 times 0 or 1 month or 2 months. It's equally effective. There's no reason to delay this vaccine, and that's what scares me. Thank you, Tara.
Thank you, Dr. Offit. Appreciate that. We're going to turn it over now to Mr. Nimberg, who will discuss. He's going to help us understand the impact in a personal way of hepatitis B, both at the personal level and at the population level. And I'll let him explain that. Go ahead, Mr. Nimberg, excuse me. I think you're on mute there still. And I forgot to say, Mr. Nimberg, he's dedicated most of his professional life to fighting for people impacted by viral hepatitis.
Thank you, Tara, and Dr. Offit. Dr. Offit, I think, very eloquently pointed out the importance of that birth dose and the results that we've seen. Incidence has dropped precipitously in the last 35 years since the birth dose recommendation was put in place. My personal connection has to do with my wife, whom I met in graduate school just over 20 years ago. And I was already working in the hepatitis field. She was born in China, where hepatitis B was endemic and had never been tested. And I suggested that she get tested. And as it turns out, she has chronic hepatitis B. She knew nothing about it. And I explained to her what it was, how it's contracted, what the long-term potential consequences are. It was likely contracted at birth. She was born in the early 70s. The prevalence in hepatitis B in China then was, between 5 and 10%, so very high. But it's possible that she could have been exposed in childhood, as Dr. Offit mentioned. It's impossible to pinpoint where people have been exposed, especially if the person's mother's Hep B status is unknown. And the good news is, for a lot of people with hepatitis B, there is treatment. For a lot of people, it remains relatively inactive. But the really scary part is that if you are infected at birth, as Dr. Offit mentioned, the likelihood of chronic infection is 90%, and adverse consequences, liver disease, cirrhosis, liver cancer, and death, is relatively high. About 20% of those infected at birth will go on to serious consequences of chronic hepatitis B infection. And that is the reason that we recommended the birth dose. My wife and I have two beautiful boys, 14 and 17 years old. My wife was screened when she was pregnant. We knew that she had chronic hepatitis B, so we were prepared to get the proper vaccinations in the delivery room. But I think one of the most important things that Dr. Offit mentioned was if a pregnant woman gets screened, and he said that many women do get missed, and there are false negatives, and so in the delivery room, there are hundreds of babies every year who are thought to be born to a hepatitis B negative woman whose mother actually is a chronic carrier. And those children are critically missed still to this day if they're not getting that birth dose. I'll just finish by saying that, this is one of our most effective public health interventions. We have the tools to prevent the consequences of hepatitis B infection. And dying of chronic liver disease is a horrible way to die. And we cannot emphasize enough the magnitude of the effect of this recommendation.
Thank you very much, Mr. Nimberg, for sharing that. We're going to move on now to Dr. Goodman, who will address some other issues that will be covered during the ACIP meetings. Again, if you have any questions, you can put them into the Q&A while we're waiting. I already see some questions in there, and we'll get to those shortly. Go ahead, Dr. Goodman.
Okay, great. I want to again thank everybody and my panel co-participants. It's just great to get together, and it's great that everybody is, concerned and active and trying to protect the health of children here. That's what this is all about. I would like to say, unlike Paul, I'm an adult internal medicine infectious disease doctor, but I want to second Paul and Michael's comments about just what a serious disease chronic hepatitis can be. As a internist and infectious disease consultant, I see many times people needing liver transplants or dying of hepatocellular carcinoma. And what I would just say is that is virtually 100% preventable. So we have a duty to prevent that. Now I'm going to go on and just comment. A whole bunch of issues have been brought up as possible issues at ACIP, and I thought I'd touch on some of them so people can have an informed approach to whatever may come out at that meeting, because it's not entirely clear what that might be. Next slide, please. Adjuvants is one. This comes from the Latin adjuvare, which means helping towards, and it helps our immune system be effective. They help our immune system mount a stronger antibody and cellular immune response against the antigens of the bacteria or virus that are in the vaccine. And that better prepare it for and help us protect ourselves against infection. Many of the antigens contained by bacteria and viruses without an adjuvant added cannot stimulate immunity strong enough to protect us or our children, or they would require additional or much higher doses to do so. Some of the important vaccines that do use adjuvants include diphtheria, pertussis, tetanus, Hep A and B, human papillomavirus vaccine, which prevents cervical cancer, pneumonia, influenza, meningitis, and H flu vaccines. Adjuvants are not present or needed in vaccines made with live viruses like MMR or used in messenger RNA vaccines like the current COVID vaccines, or the majority of them. Adjuvants are only used when the response to the vaccine alone is insufficient to protect us. Regulators will not agree to use an adjuvant in a vaccine if it's not needed. Next. Now, what about aluminum salts as adjuvants? This has been raised by some people as a concern. The most commonly used adjuvants are aluminum salts. They've been safely used in vaccines for about 100 years and have been received by billions of people. They strengthen our immune response and keep the antigens of the vaccine from disappearing too quickly. Now, aluminum sounds like something unusual, but it is a common metal making up 8 to 9% of the Earth's crust. And it's in our everyday diets, which are the main source of aluminum. Adjuvanted vaccines typically have a half milligram or less of aluminum in a dose, while our aluminum intake from diets is 7 to 9 milligrams typically every single day. So, an order of magnitude higher. The amount of aluminum from all vaccines given in the first several months of life is less than that from breast milk and far less from that contained in infant formula. Whether from eating our vaccines, aluminum has the same fate. It's rapidly excreted by the kidneys, and most of a very small amount that's retained in the body came from foods and not from vaccines. Next slide. Aluminum adjuvants have not been associated with health problems. Aluminum in high doses in people with severe kidney disease can cause toxicity. However, aluminum exposures from vaccines is below limits set to avoid toxicity. A study of over 1 million Danish children followed over 24 years did not show any changes in health associated with aluminum exposure from vaccines. And diseases included in the studies included allergies, autoimmune disease, autism, and other neurodevelopmental issues. Another study found no correlation between infant blood or hair aluminum concentrations and the history of vaccination with aluminum-containing adjuvants, or between blood aluminum and development. One small study did suggest a slight increase in asthma with high aluminum exposure. However, multiple larger studies have not shown such an association, and in one study, aluminum exposure was actually associated with less autoimmune disease. Next slide. There are challenges and impacts with removing adjuvants, even when there's not a reason for doing it. Without adjuvants, as I said before, you'd need additional or higher doses of vaccine, resulting in more shots and potentially more adverse effects. There would need to be large, costly new clinical studies to ensure the non-adjuvanted vaccines are as safe and effective as the currently licensed adjuvanted ones. And then while there are other non-aluminum-based adjuvants in some approved vaccines, and I've listed some of them, they have not been used as long or as widely, and while safe, generally cause more local and systemic reactions. Next slide, please. Now, what about combination vaccines? People have said, why do we have to get so many different things at once? Isn't this harmful to the immune system? Well, why? Combination vaccines actually reduce the number of shots that people, especially children, need. Receiving MMR together or DPT antigens together, a child needs just 1 shot instead of 3 for every dose. So if you break up MMR, it results in kids needing a series of 6 shots instead of 2, so 4 extra shots. And if you could, which you can't, break up DPT, it would result in kids needing 15 shots instead of 5. And you can do the math for other combination vaccines that contain, 5 to even 7 different disease protection antigens. Combination vaccines undergo complete review by FDA before approval. They are studied in their combination, and they undergo safety monitoring after they're approved. And it's very natural for the immune system to be exposed to multiple bacteria and viruses every day. Vaccines help train it, but without the disease. Because vaccines that are made now are increasingly sophisticated and pure, children are exposed to less vaccine antigens than years ago, despite being protected against more diseases by more vaccines. And there is no evidence the immune system can't handle combination or multiple vaccines, or that they're associated with any chronic diseases. Next slide. Now, just like with adjuvants, there are challenges and impacts from breaking down combinations into individual vaccines, spreading them out, etc. You'd have lots more shots for kids, lots more healthcare visits, costs and strains on already stressed parents, providers, and care systems. We know many more people would miss doses or end up unvaccinated, hurting them and making the community and schools for children less safe. Large, expensive clinical trials would be needed in some cases, and manufacturers may need to retool their manufacturing, costing hundreds of millions of dollars, with increased costs for syringes, vials, shipping, and storage, all creating supply chain risks and access issues, especially for most who are in need, all to fix a problem that does not exist. Next slide. Now, I want to finish up this sort of smorgasbord of potential issues, because there's a long list, by talking about vaccine safety a little and the vaccine adverse event reporting system. Part of the reason for talking about this is many of you may have seen over the weekend, an FDA email was released containing allegations that there may have been 10 pediatric deaths related to COVID vaccine. So what is VAERS? VAERS is the Vaccine Adverse Event Reporting System. It's co-managed by FDA and CDC. Anyone can report any event possibly associated with vaccination, but a report does not mean the vaccine caused the event. It's important to keep in perspective that many serious events already occur, and sometimes quite frequently, in unvaccinated people. We get sick all the time, and for other reasons, which are not always known. So they can and will occur coincidentally in the days following a vaccine. This doesn't mean that VAERS reports do not show a problem, but it means they need to be considered carefully. And for example, in the US, sudden cardiac death occurs in 1,000 people a day, strokes in 2,000 a day. And while much less common to have severe outcomes in infant, each year there are 20,000 infant deaths, 4,000 deaths approximately in 1 to 4-year-olds, and 6,000 in 5 to 14-year-olds. So we can see a situation where these events are occurring, and it's not surprising to find that some people have been vaccinated before such an event. VAERS is useful and important in bringing possible adverse events to attention, what's been called signal detection, but review of the VAERS cases alone cannot usually determine if a vaccine actually caused the event or how frequently it does. It reminds me of kind of radar. Is this friend or foe? You need to know that before you take action. And finally, for these reasons, to investigate the events of concern requires additional steps. This includes detailed review of the cases, including medical records and testing, imaging, and pathology, to see is there a consistent pattern in findings among these cases. For example, documented myocarditis with similar findings in a certain time interval after vaccination, and have alternative causes for myocarditis, multiple other viruses, including COVID, have they been tested for and excluded. And then, if you believe you have a signal, controlled studies using healthcare-related databases with typically millions of individuals usually must be performed to tell if an event in VAERS truly is occurring more after vaccination compared to at other times or compared to unvaccinated people, and if so, how much more often. You're asking, comparing vaccinated individuals to controls, is a signal confirmed to be due to an actual excess of confirmed cases in the population studied? All of this evidence, VAERS and the healthcare database evidence, is taken together, and important to have the analysis public of the FDA and CDC staff scientists who are expert in looking at and analyzing this data. It is usually then presented to the larger medical and public health community and outside experts for further input, assessment, and consideration of any needed actions. So I hope that places VAERS in the adverse event system in context, and look forward to our discussion. Thank you.
Thank you, Dr. Goodman. And hopefully your presentation and Dr. Offit's have answered some of the questions that we have coming in on the Q&A. I want to, I'm going to post something right now, and I've been putting some figures into, or excuse me, some links into the comments for everybody. And I'm about to put a comment into the link that will address one of the questions that came in, but I'd like Dr. Offit to also address it. We have a question from Chris Hahn on what specific data refutes the idea of delaying the birth dose for children whose mothers test negative during pregnancy. And he understands the general concerns that she could be infected after testing. And you mentioned the false negative rate, and that others in the household could be infected, but what are the odds of that? And I'm also going to put in the chat right now a study that was just published today that looks at the cost in terms of cases, liver cancer cases, and deaths, as well as healthcare costs for the delaying the birth dose to 2 months. So you can look at that. But go ahead, Paul.
So, I mean, if you choose to delay the vaccine till 1 or 2 months of age, you do know that there's about a 5% false negative rate. And you do know that the child can contract hepatitis B from coming in contact with someone who has chronic disease, many of whom don't know it. I think the odds are very small. I think the chance that you're taking is a small chance. But what's the benefit? I mean, the benefit is the vaccine is no more safe or effective if given at 0 or 1 or 2 months of age. Also, the incubation period of the virus is about 2 months. So do you really want to wait till the end of the incubation period? I mean, or in the middle of the incubation period? So I guess what upsets me about this is I feel, having lived through, I was on the ACIP from 1998 to 2003. And that was the thimerosal era, where there was a concern that as we were giving more and more vaccines, that some of these vaccines were in multi-dose vials, that multi-dose vials contained this ethyl mercury containing preservative, that was just too much. Now, there was a lot of data at the time, because this was, because Western Europe had taken thimerosal out of vaccines in the early 90s. There were Canadian provinces that used thimerosal-containing vaccines right next to those that didn't. There were a lot of natural experiments that answered that question. You were at no greater risk of any neurodevelopmental problem if you got that vaccine or if you didn't. But mercury didn't sound good. And and that's what this was all about. It was about making people feel better by just saying, okay, we'll just move from multi-dose to single-dose vials. And that's what I feel like this is. It is hard to watch your child get a shot in the first 24 hours of life, although getting through that birth canal is not fun either. So I think that should be considered. But I think that there's no benefit, and there's only risk even if it's a small risk. So why take it? Why take that risk even if it's small? I guess is what I'm saying. So I guess we'll find out. I mean, if we find that more and more people are not giving the birth dose, given what we know about the fact that there are risks, we'll find out what that risk is. But do we really want to do that?
Thank you. And I'm going to stick with the birth dose again in a minute, because I have a lot of questions that are all kind of related to one another. One person asked why this issue has been raised by ACIP in the first place on the hepatitis B. That was from Laura Lee Hall. Isaac Benowitz asked that he hears all these vague suggestions about why Hep B is coming up in ACIP right now, but can you shed effort and light, like broader light on the efforts from MAHA to raise this issue so that they can, journalists can address more head on what the most common concerns are. And then Jenna Cogden asked if you can explain the argument for no longer recommending the birth dose. Is it based fully on non-science-based anti-vaccine rhetoric, or is there a realistic drawback? Okay,
so let me take this one first, if you don't mind. The hepatitis B birth dose has been a target of the anti-vaccine movement for years. Initially, when the hepatitis B birth dose was recommended for all, the thinking was it's causing sudden infant death syndrome. That was the thing. Actually, if you look at the data then, as the incidence of hepatitis B birth dose increased from the 90s, say early 90s to 2000, the incidence of sudden infant death syndrome actually dramatically declined. I mean, if you looked at those data, you would assume the hepatitis B vaccine prevented sudden infant death syndrome, which wasn't true either. What happened was in the early 1990s, the American Academy of Pediatrics recommended their so-called back to sleep program, which is to say children were much more likely to die from sudden infant death syndrome if they were laid on their stomach than on their back after feeding. So that's what that was. But I just think it's a low-hanging fruit for the anti-vaccine movement. That's what drives this. I mean, there's an enormous amount of data that it's not a safety issue. I mean, it's a single protein vaccine that induces a T cell dependent B cell response, which children can do very well from the minute they're born. I think there's no real safety issue. I think this is all driven by the anti-vaccine movement. And now we don't have an ACIP anymore. We have a group of people who have an anti-vaccine, anti-science bias, much like our Secretary of Health and Human Services, that are now doing what he wants them to do, which is to sort of attack these things that they've been attacking for years. Except now they're going to be able to attack it by having people making public policy who are basically created in the image of Robert F. Kennedy Jr. So I worry for our children. I wish we could call it something other than the ACIP. And frankly, I wish we could call the CDC something other than the CDC, because it's not the ACIP and CDC anymore. I don't think the medical and scientific community looks to either of those groups to help them make decisions, because they're not to be trusted. You have people like Rochelle Walensky, former head of the CDC, or Tom Frieden, former head of the CDC, saying, I don't trust the CDC anymore. And I think a lot of people are standing up now to create their own, advisory groups like AAP, ACOG, and different states are doing that. It's a troubled time.
Mr. Nimberg, would you like to add anything to that?
Oh, I'll just agree that, I mean, the HPV vaccine is one of the most extensively studied vaccines that we have. So we know what the safety profile is. And I'll just point to the article that you dropped in the chat, Tara. By delaying the birth dose just to 2 months, the modeling shows that there could be at least 1,400 preventable hepatitis B infections among children, 300 excess cases of liver cancer, almost 500 preventable deaths, and over $200 million in excess healthcare costs. So, of course, this is a very, personal decision. Parents always want the best for their children, but this is something that can not just prevent the personal grief of contracting a preventable illness and going on to the possible consequences, but it's a effective, incredibly effective public health intervention. And the money that is saved by preventing these infections is in the hundreds of millions per year. I'll just give one quick example. My wife has chronic hepatitis B. She's in her early 50s. To this day, she still requires an annual ultrasound to screen for liver cancer. And that's not trivial. It takes time out of her day, it costs. And so you multiply that by all of the potential preventable cases, that does amount to several hundred million dollars per year that would be saved.
Michael, can I ask you a question? The numbers that you gave in terms of delaying the birth dose till 2 months of age, did that include all comers, and including those women who were screened as being hepatitis B surface antigen positive in the first trimester?
It's among infants whose mothers are not known to be living with hepatitis B.
Wow, that's amazing.
Thank you. I'm gonna ask one more question related to Hep B, specifically with how ACIP has changed something, and then we're gonna go on some of the other questions, and then we'll loop back. The ACIP agenda has switched days for the Hep B discussion. Some of you may have noticed that it was originally planned for Friday, and it's now planned for Thursday. Did they do that so that people who had registered for comments on day 2 would be making their comments after the votes had occurred on day 1? So just switching the agenda make it so that people can't now, well, you see what I'm saying? Like, if they were going to speak about hepatitis B vaccine on Friday and now it's on Thursday, what Could that be? And also, is switching that agenda, does that violate any aspects of the Administrative Procedures Act or something similar that could make the votes invalid or subject to administrative or legal review? This question's from Mike Miller. I assume this is a Paul question because I know you served on ACIP.
No, I think Jesse may be able to answer this better than me.
Oh, okay,
I don't
Jesse.
know.
On the legal issue, I'm not sure, but it certainly violates the spirit of how advisory committees are supposed to function. There's supposed to be adequate notice and time for people to register to comment. And also, what we saw at the last meeting, for instance, is presentations being dropped at the last minute with hundreds of references so that other people reviewing them had no opportunity before the meeting to see them. I'm a little worried that that could happen this week, that perhaps this pediatric COVID concern could suddenly, appear on the agenda. So it is very worrisome, and I am concerned about violations of, at the very least, the spirit of the Federal Advisory Committee regulations.
So mentioned two law professors who can give more information on the legalities there, Dorit Reese and Richard Hughes III. There's others, but those are two I know of offhand. We're probably going to stick with Jesse here, although Paul might have something to add to this. Can you explain the mechanism, the plain language explanation of how aluminum salts boost the immune response? Like what's actually going on there mechanically?
From what we know, they both seem to directly at that place make your cells that kind of respond to foreign materials like macrophages, B and T cells more effective at doing that. So right at that spot, they do that. They also bind to the protein in the vaccine and make it not disappear just within a few minutes and be there long enough for the immune system to respond to it. So those are some of the things that we do understand about it, but the immune system is quite complex. They do improve both the response of what we call our B cells, which make antibodies that everybody's heard about, and also of our T cells, which are particularly important in protecting against viruses. So they act in many ways, and for what they do, as I've pointed out, they have an extraordinary safety record.
Paul, did you want to add anything to that, or is that good?
Yeah, the only thing, it used to be thought that aluminum adjuvants work by the so-called, as Jesse said, a depot effect, meaning you sort of kept that antigen there for a longer period of time during which the immune response could respond to that antigen. Now there's more data on the fact that there are specific cytokines and chemokines that are being induced through immune mediators like interleukin 17 and others that are associated with that as we learn more and more about these aluminum adjuvants. But as Jesse said, I think we started using aluminum adjuvants in 1926, and it's been 100 years of this. We have a lot of experience with these adjuvants, and they're necessary. There's no taking. I mean, we never took thimerosal out of vaccines. What we did is we moved from multi-dose to single-dose vials. There's no taking aluminum adjuvants out of vaccines. You would have to use different adjuvants, and these companies aren't going to do that. They're not, nor should they. There's no reason to.
And that question, by the way, was from, pardon me?
I was going to say, and as I said, the alternatives are multiple more doses, higher doses, which come with their own problems, potentially, and adverse events. And then the other adjuvants are less well understood and tend to have more reactions, even though they've been safely used in multiple vaccines. So, as Paul said, not trivial to change them, very strong safety record. I think the other point that people kind of miss, like in a tiny dose of the antacids we take every day, they're full of aluminum at levels much, much higher than you'd ever see in a lifetime of vaccines. So it's important to keep in context that this tiny exposure from vaccines is a very small portion of our overall exposure.
That question, by the way, I forgot to mention, was from Beth Rubenstein. Another question from Jody McCreary on the larger scope, and we were actually discussing this just before we started here. What do you make of this week's ACIP changes with Koldorf being moved to a different job and now Milhone the new chair and ostensibly one fewer voting member? And what effect might those changes have on the hepatitis B vaccine discussion and vote? I don't know who wants to take that first.
I think the world has turned upside down. I mean, here's the way it used to work. The way it used to work is that people at the CDC, veterans at the CDC, would present data to the ACIP based on their research. Fiona Havers gave an excellent presentation in April of 2025, and we still had a CDC before it was shredded. And she presented to an ACIP that consisted of 17 people who had an expertise in virology, immunology, bacteriology, public health. They were clinicians, et cetera. We don't have that anymore. We have a CDC which has been co-opted by Robert F. Kennedy Jr. and an ACIP that is not a group of experts. Rather, they have an anti-vaccine, anti-science bias. You have people like Robert Malone saying, I'm proud to be called anti-vaccine. You have people like Vicky Pebsworthy or Pebsworth or something like that. She used to be Vicky Diebold, who works for the National Vaccine Information Center, which is an anti-vaccine group, lobbying states to eliminate vaccine mandates. So it's just not the ACIP anymore. So I don't know what to expect. I mean, I can tell you every time they meet, I think all of us hold our breath waiting to see what's the next dangerous piece of advice that they come out with.
Jesse, do you want to add anything to that?
Um, you know, I think we always hope for the best and people will consider information carefully, but you know, as Paul said, many of these people have existing bias. It appears that the new appointed chair may. So I think we're going to have to see. I think one of the things that really does concern me is that the voices of the staff scientists at CDC, as Paul said, appear to be being muzzled. And this is, you know, it doesn't bother me if a senior leader or political leader questions what they say, but that should be an open in the public and a debate. At the last ACIP, I remember one CDC presentation was actually taken down from the website right before the meeting. So if you want to get at truth in science, you hear different views of it and you include views from the people who know the most about it. And what worries me is we get these last minute agendas, we get anecdotes, we get presentations that nobody's heard before, and there's not an appropriate vetting of the information, and it doesn't include internal scientists free to express themselves without the risk of getting fired.
Yeah, well, here's what it reminds me of. When I was in high school, I remember you used to have this mock UN meetings, you know, you'd be sort of the mock UN General Assembly, and you would decide like the fate of Rwanda or something. I mean, it would be like that now, except you would actually fire the entire United Nations General Assembly, and then we actually would determine the fate of Rwanda. That's what it feels like. It's just like you just can't trust it.
Yeah, and I think the other thing that's very concerning is excluding the professional organizations from the working groups that develop CDC recommendations. So there are not enough voices of people who actually take care of patients and people who you know have deep experience and understanding in the science. Again, I am fine hearing other voices, but those voices should not be removed. So we had a situation at the last ACIP where the notion that people could just, you know, get appointments to get counseling about their vaccines, or that, you know, pharmacists could do, you know, do informed consent for everybody. Some of these things that just didn't comport with the reality of what life is like for parents and healthcare practitioners. Now, I want to say there are some people on the committee who do know that, so I don't want to say that about everyone.
Michael, did you want to add anything to that? Just as a patient advocate, seeing these changes happening?
Sure. I would just add that I think the most dangerous part of this whole conversation is sowing doubt in the minds of parents. And parents are going to do what they think is the best for their children. And if they think that there is any risk for their child in getting some of these vaccines for diseases that they don't know or understand or have seen in the real world, then that hesitancy is only going to increase. And if they can put it off, they will, without really appreciating the value in getting those vaccines when they are recommended, because those the timing of those recommendations has been one of the most important pieces of the recommendation based on the science and the risk of exposure and infection. So I would just say that the sowing of doubt is probably the most dangerous part, because parents are going to just kick the can down the road oftentimes if they can.
I'd like to add one thing to that too, which is the complexities of the way they propose to make certain changes and things about decision making, et cetera, make it confusing for pharmacies, parents, healthcare providers, and make access that even for those who still decide, I want that dose of vaccine for my child or for myself, they create barriers, even though they're saying, well, it'll be accessible to everybody. They create barriers in the real world. And those things also lead people who maybe can't afford the time or money to forego vaccination, even if they have decided they want it.
A question probably for Paul, maybe for Jesse. Could one of you explain the evidence to recommendation framework that was previously used by ACIP to make recommendations, and what it means that this framework is no longer being used?
Yeah, so the so-called ETR, evidence to recommendation, is that before a vote, there's typically one person that presents the evidence before that vote. That in order for that talk to occur, that talk has to be reviewed by subject matter experts. You saw an example of how that didn't happen during the June meeting when Lynn Redwood, formerly of an anti-vaccine group called Safe Minds, then she was part of the Children's Health Defense. She didn't have her talk reviewed. And so initially in the talk, there were references that didn't exist. And there were also statements made about various references that what wasn't actually the conclusion of that study. And some authors stepped up and said, wait a second, that's not what we concluded. So that was just a freewheeling sort of anti-vaccine presentation. And it led to a 5-2 vote against thimerosal-containing influenza vaccine. So that's typically what ETRs are, but you're right, the rules have changed.
That question was from Max Bernhardt. A question from Lena Sun at WAPO. She said that the new chair of ACIP said the panel is going to be looking at links between cumulative effect of multiple shots that kids get and the rise in allergies and autoimmune disorders. Are there studies out there that have cast doubt on a link between vaccines and autoimmune disorders specifically?
So there was an excellent study that was published in Annals of Internal Medicine recently by Anders Vid, HVID was the senior author. And what he did was it does in a sense sort of answer this question, which is he looked at from 1997 to 2020, so over a 23-year period, during which time children would get a variety of different diseases as more and more vaccines were added to the schedule. And then what he did was he was looking at aluminum specifically to look at any children who got anywhere from 0 milligrams of aluminum up to about 4.5 milligrams of aluminum, and then looked at 50 different disorders, among which were included autoimmune and allergic disorders, and found no relationship between getting vaccines, in which would be more or less vaccines, and those disorders. I mean, he wasn't really looking at that specifically. He was looking at aluminum specifically, but in some ways that did answer the question.
There's been some concern that was raised at the last ACIP meeting. This is a question from Elizabeth Perea, that if a newborn develops a reaction like a fever after the birth dose, clinicians may pursue a more invasive evaluation and treatment than they would for an older infant. How can you best respond to that concern if parents are worried about that?
Right. Well, I mean, the hepatitis B vaccine, the birth dose vaccine, is really remarkably safe. I mean, I think the chances that it causes fever are extremely low. So but certainly it's a reasonable concern with anything that causes fever. But again, that's probably why it was a good idea to not have the MMRV given as a 12 to 15-month-old, because that's the time when you're most susceptible to febrile seizures. And so let's give it as 2 separate vaccines. That made sense. But sure. I mean, I think any vaccine can cause fever. And but I think, you sort of take it in the whole for how the child looks, in addition to the fact that they just got a vaccine, which could explain it.
sort of along the same lines of that, a question from Carol Morton. She saw a newsletter from an anti-vaccine advocate that had the confession of a NICU nurse who faked giving vaccines to infants in her care. She wants to know what vaccines are given to premature babies and what their relative vulnerability is to the diseases they're being vaccinated against. And I presume this probably means, correct me if I'm wrong, I think depending on how premature they are, sometimes the vaccines are delayed, the 2 month and the 4 month are delayed, but I don't know how it's, I think it's, you have to be a minimum of 4.4 kilograms, I think, is that right? Or pounds, excuse me, for the birth dose of the hepatitis B, is that correct?
You're asking me what the dose is?
Yeah, well, she's asking which vaccines are given to premature babies, and from my recollection, they give the 2 and the 4 month vaccines according to what the gestational age would have been, as opposed to actually 2 months after birth. But I also recall that the hepatitis B vaccine is recommended for all infants that I think are 4.4 pounds and older. Basically, what do premature babies get? Is the question.
Well, again, I agree with you. I think most of them, you sort of wait until they are what would have been, their normal age, accounting for the fact that they were severely premature. So you wait until they reach what would be their normal age, So if they're 24 weekers, you wait that 16, you add those 16 weeks so that, that you give them the vaccines later when they're technically older. But I mean, all vaccines are recommended for children born prematurely. You just sort of account for their prematurity.
And I think, Paul, you would know better than me, but I think the birth doses hepatitis B is not given immediately if they're underweight or significantly premature.
Right, that's right. It's what Tara said. You wait until they're a certain age,
Right.
or wait.
And someone just shared, I think it was Tabitha, the CIDRAP. It was just published today, their review of the hepatitis B vaccine. So I'm putting that into the chat just now. Could the panel speak to the possible impact on vaccine confidence in the public that these changes at ACIP recommendations could cause? And I think you've kind of already addressed that. Is there anything you want to add on that? And are there impacts such as, could the vaccines be included from the VFC program? Related, that's a question from Sheila Thompson, but I'm going to combine it with a question from Helen Branswell that asked, what would be the impact if ACIP votes to make Hep B a shared decision-making administration, since parents already have the option of declining the dose, and how that might affect either the VFC program and or the vaccine injury compensation program?
Yeah, I actually asked Dorit Rubenstein-Rice at UCal Hastings the second part of that question, meaning if we move to, so for example, COVID vaccine has been moved pretty much solely to shared clinical decision making. There is no specific recommendation for any high-risk group, but that has its own sort of liability protection, it has its own system. So I asked her what would happen, for example, if we made MMR vaccine shared clinical decision making. Would that mean then it's not covered by the vaccine injury compensation program? She said the law is not clear there. So that's a risk. And then the other thing in terms of making it so if it's not recommended and it's all shared clinical decision making, will the vaccine for children's program cover it? I'm not sure. I mean, I can tell you that in our state, in Pennsylvania, Governor Shapiro is now creating his own vaccine for children's program because he's afraid that might happen.
And Michelle Fiscus, who is the director of the organization in charge of all state immunization managers, corrected me. Thank you, Dr. Fiscus. Saying that vaccines are held until the infant is at least 2 kilograms and given according to life age, not gestational age. So I mixed that up. Thank you. Would parents still have the option to get a combination vaccine if they wanted to for their children, if it was not officially recommended? Question from Jenna Cogden.
Well, so by delaying the birth dose, you do make it confusing. So I'll give you an example. There are 3 vaccines, combination vaccines that have hepatitis B in it. So Pediarix, which is DTaP, Hep B, IPV, Vaxelis, which is DTaP, IPV, Hib, Hep B, and then Twinrix, which is HAV and hepatitis A vaccine and hepatitis B. So the first 2, Pediarix and Vaxelis, are given at 2, 4, and 6 months of age. Twinrix is at 0, 1, and 6 months of age. I mean, typically the hepatitis B vaccine is given at 0, 1, and 6 months of age. So it would be confusing, I think, is what would end up happening. That's what worries me in all this.
2 other questions I'm going to kind of combine. One is that we need more information for parents, especially because it's often the hepatitis B vaccine is not brought up until right after delivery, which is not a great moment for parents to make a clear-minded decision. But then there's all this misinformation about it. Is there is there any way that people are measuring the impact of these changes at ACIP's effect on public confidence about these or on incidence of receiving the vaccine, excuse me, vaccination rates? Is that something that people are doing?
Yeah, so in terms of this ACIP, this new ACIP was put in place on June 11th. So it hasn't been a lot of time with them in place. Do I think that they have scared more people away from vaccines? There's certainly that potential, but I don't know. I don't know. I mean, I think we're about to find out over the next few months and years
Okay.
whether or not that's true.
And I will say for that, there are a lot of vaccine hesitancy researchers who do a lot of that kind of work. I know Sean O'Leary at Colorado has done some of that work, and and there's many others. So I expect we will be seeing some of that. A good question from Elvia Malagan. How can states or medical advisory groups do anything to override what the ACIP votes on later this week? Or will the ACIP vote limit the availability of the Hep B vaccine across the country, regardless of whether states issue recommendations that contradict the ACIP?
Well, so I think COVID is an example of that. So what happened was Fiona Havers presented data in April of 2000 of this year, April 15th, 2025, showing that children are still getting hospitalized, children are still getting sent to the intensive care unit, and about 150 children died of COVID last year. And nonetheless, Robert F. Kennedy Jr. said that we, HHS, are no longer to recommend this vaccine for healthy young children. And then the CDC recommendation schedule changed, the table of schedule table changed to just have it as shared, ultimately sort of went to shared clinical decision making. So there wasn't a clear recommendation for young children. So the AP responded immediately, published in their journal, Pediatrics, something that clearly said children who've not been vaccinated or naturally infected need to get this vaccine. And RFK Jr. immediately attacked them, said that they're on the pocket of industry, and he's not. And but the AAP did work with insurance companies to make sure that insurance companies would follow the AAP recommendation. And at least my sense from talking to people like Sue Kresley, who's president of the AAP, is that they were able to get that, which makes sense. I mean, it's much cheaper to pay for a vaccine than a hospitalization. So the sense I got from her was that the insurance companies were following what they thought were best medical practices.
Good question from Barbara Rodriguez. I see this a lot from anti-vaccine advocates. She's the 19th. How do you respond to claims made about other countries' approach to the Hep B vaccine? Some ACIP members have made vague references at the last meeting in September to other countries not requiring newborn shots. How do you respond to people who make that argument?
Well, so Morten Koldorf made that argument. He basically said, look, he's from Denmark. Denmark doesn't give the hepatitis B vaccine until 2 months of age. So why are we doing it here at birth? But we're not Denmark. We're not Denmark in a couple of ways. One is that in Denmark, you have roughly 100% of women are screened in the first trimester. That's not true here. People are more likely to fall through the cracks here. They have a national health system. We don't. And secondly, I think the incidence of chronic hepatitis B may be greater in Denmark than it is here. I don't know. I'd need to look that up. But that is, that's the other possibility is we're not Denmark. And about half the countries out there, when they went through these data, have a birth dose. The other half can delay to 1 or 2 months of age. But I think it's a risk in this country not worth taking.
I would add that the majority, WHO recommends the birth dose, and the majority of countries in the world do it. And they may choose not to do it because, as Paul said, they may have lower levels of disease or very high levels of screening. But in our country, there's a lot of people who aren't screened and don't even have health care.
We have so many other. Go ahead, Michael.
I was just going to say, if you look at a country like China, I mean, through universal birth dose vaccination, they've seen their prevalence drop from about 10% 35 years ago to 3%, and that's attributed mostly to the universal vaccination.
We have a lot of other great questions, but unfortunately we are out of time, and I apologize for that. But thank you everyone for joining us today. We really appreciate you coming in, and thank you to Dr. Offit, Dr. Goodman, and Mr. Nimberg for helping us understand these key vaccine issues. We will not be sharing Dr. Goodman's slides published, but this recording will be published by tomorrow. If you joined us late, you'll be able to watch that tomorrow. Thank you, everybody, and good luck on your reporting.